I'd like to begin by acknowledging that I live and work on the traditional unceded territories of the Hankaminam-speaking people, the Musqueam and Tsleil-Waututh nations, and the Squamish-Snitcham-speaking people, the Squamish Nation, who are the original stewards of these lands. And I would also like to acknowledge all of the co-authors on the two papers that I'm presenting today. They have not been published, so I ask that you not share any photographs of these slides, but we hope to publish them soon. What is really great about our list of co-authors is that it includes several community members, trainees, reproductive and public health researchers, a physician, a midwife, a nurse, a legal scholar, a social worker, a sexologist, and an economist. And it's been a true privilege to work with such an interdisciplinary group of people who have different perspectives on the research, which really strengthens the manuscript. I also want to thank Vanessa for creating the slides with me. I want to begin by situating the research within the larger context of healthcare quality, beginning with the WHO, who in 2016 published standards to improve the quality of maternal newborn care. In that report, experiences of care are described as a core component of quality of care, whereas previously the focus was much more on physical health outcomes. And then following up on that report, the WHO published 3 guidelines about how to improve perinatal experiences during pregnancy, birth, and the postpartum period. And each guideline highlights autonomy through a human rights-based, person-centered approach that is tailored to each stage. We also see a focus on the patient experience in most healthcare quality frameworks. Here at the top, I copied the BC Healthcare Quality Framework, and the first dimension is all about respect and honoring patients' choices, their needs, and their values. And of course, most of you are familiar with the quadruple aims of health system improvement, which also centers the patient experience at the top, in addition to advancing health outcomes, reducing costs, and improving the healthcare provider experience. And we know from research studies that when patients are supported in their autonomy and making autonomous decisions, they tend to have more empowering and positive experiences. And on the flip side, when there is coercion and lack of consent, this often results in negative and traumatizing experiences. So it's really important to get this piece right. Autonomy in perinatal care, the ability of childbearing people to lead decisions about their care, is a fundamental reproductive right and a core component of person-centered and respectful care. Autonomy is supported when providers share unbiased evidence-based information about the pros and cons of different options, give patients enough time to weigh their options, and then respect their preferences. And that last piece is really important. However, we still see lots of violations during maternity care, such as coercive practices, biased communication, and disregard for people's knowledge of their own bodies and their cultural practices. There is limited research on the association between loss of autonomy and other outcomes. We know from qualitative studies that people who experience loss of autonomy tend to have less trust in their healthcare providers and the healthcare system at large. They have worse birth experiences, and some have lasting trauma. On the quantitative side, on the right here, we have seen studies linking loss of autonomy to postpartum depression, PTSD, and even some studies that show the impact of observing loss of autonomy. This study here at the top bottom right, I was involved in as a supervisor, and this is basically a study where midwifery students answered questions about observing loss of autonomy and disrespectful care during their placements. And the students who had witnessed more of those negative experiences were more likely to have PTSD symptoms directly related to those observations, and they were also more likely to want to quit their program. So we can see how loss of autonomy not only impacts the childbearing person, but through secondary observations, also healthcare providers and trainees. Now talking about the research that I'm presenting today, we are going to present data from the RESPECT study, and I'll tell you a bit more about that study in a moment. But essentially, we hypothesized that experiences of autonomy during pregnancy are embedded within structural inequities and will be affected by social position, adverse life circumstances, and pregnancy factors. And also context of care, like what type of provider do you have? Did you get prenatal care as early as you liked? And such things. Groups who have been marginalized on the basis of indigeneity, immigrant status, race, disability, substance use, gender, and other factors may face power inequities around decision-making. And this has been documented in related areas of perinatal care, but not really with respect to autonomy in the large-scale studies, such as the RESPECT study. So our team at the Birthplace Lab, together with community members, designed a study to assess inequities in people's ability to lead decisions about care. And we also wanted to know if there's anything that improves autonomy, because we are committed to not just researching problems, but also offering solutions. Many of you have seen slides around the methods of the RESPECT study, but I will quickly go over it again for those of you who are new to the study. So we launched a national survey around perinatal experiences with care in Canada, collected data between 2020 and 2022, translated the survey into 7 languages, and then did very extensive recruitment through social media, organizational partners, professional organizations, and 18 recruitment coordinators who kind of reached out to their own networks and did sort of mouth-to-mouth recruitment and recruitment on social media. We ended up getting people participating from all provinces and territories in Canada, resulting in 6,096 participants who provided data. And the data included some measurement scales that I will discuss today, and a lot of sociodemographic characteristics and a lot of items around respectful maternity care. And then also care context variables. Now, the main outcome measure for this first set of results I'm going to show you is the My Autonomy and Decision-Making Scale. It's a 7-item scale that is shown here in the table. And prior to completing those items, people are asked, please tell us what provider type you'll be rating in terms of autonomy and decision-making, and to which degree they facilitated autonomy and decision-making. And the options are usually family physician, obstetrician, midwife, nurse, nurse practitioner, and other. So when people complete the scale and they get a scale score, which will range from 7 to 42, we know exactly which provider type they are talking about. And in the RESPECT study, we gave people opportunities to provide 2 scores. So they could rate a midwife that they had in pregnancy and then a second midwife, or they could rate a midwife and then an OB. And 1,660 people provided a second Madam score. So higher scores mean more autonomy and lower scores mean lower autonomy. Now, who responded from across the country? So to the left hand here at the top, you can see a map that was generated based on the postal codes of where participants resided during pregnancy. And you can see that there is a lot of, accumulation around the border, but also quite a few people in more rural and remote areas. In fact, we had about 220 people who lived in communities with less than 1,000 people during pregnancy and participated in the survey. To the right-hand side, you see the breakdown by region, with most participants responding from Ontario, BC, and the prairies, but good proportional submissions from all the other areas too. Now, when we study something, we like to establish that people want the type of care that we're studying. So one of the questions in the RESPECT survey was, how important is it for you to lead decisions about your care and the care of your baby or babies? And here you see that almost 90% said it's extremely or very important. And we've known this all along, but it's good to reestablish that this is really a top priority for the majority of childbearing people. I will skip over this slide pretty quickly, but I'm showing this to you to see that I think our efforts to recruit people from different communities was successful. And maybe I'll highlight here that prenatal care was received mostly from OBs in the sample. 38% of people had OBs, 33% midwives. And then we had also people who received care from family doctors and nurse practitioners. Now I'm going back to the MADAM score. So I told you that some people submitted 2 scores. So the total number of scores we had exceeded our sample size. And we had 7,046 scores. And the mean was 28.6, which is, sort of towards the higher end because the top score is 42. Now, what's more important to pay attention to on the slide is the differential distribution of those scores among RESPECT participants who rated physicians versus midwives. And I've known that to be true from analyzing this data from previous studies, but it's just really good to have a visual kind of reminder of that. So on the left, you see the distribution for people rating physicians. And here I should say that I grouped family physicians and obstetricians together. I normally wouldn't do that because they have different scopes of practice. But when I looked at their MADAM scores, they were more or less identical. And that is why I made the decision to put them together. So I wouldn't have to kind of show results for 3 different groups for family physicians, OBs, and midwives. This makes it easier to understand. So you can see that people rating physicians, they had all kinds of different MADAM scores. They had a peak at 7, which is the very lowest autonomy score, and then a peak at 42, and maybe another peak at 35 or 34, and then everything in between. When you look at people rating midwives, it's skewed very heavily towards positive scores, towards high autonomy. And you see that the most common score here for those rating midwives is 42. So keep that in mind because I will refer back to that distribution to kind of rationalize some of the decisions that were made during the analysis. So the other thing that's important to look at is, did autonomy change over time? Because people could participate if they had a pregnancy experience going back 10 years. So from the date they completed the survey, they could go back as far as 10 years, and they could choose the pregnancy they wanted to talk about. So we gave people the option of picking which one. And here you see the temporal trends for midwives in green and for doctors in red. And you can see that autonomy among midwifery clients remained steadily high for all the years that people reported on. Whereas for doctors, we started low and then we had a very steady increase over the years. So that is a really great news story that there's been an increase among people rating physicians, which indicates that perhaps over the years we're moving towards more person-centered models of care. But it also shows you that we probably need to take the pregnancy year into account when we do the analysis, not just because of these temporal trends for healthcare providers, but because COVID was kind of included in our data collection period, and care experiences during COVID might be different. Now, I'll try to go over this pretty quickly so we can get to the results. But essentially, this is to show you that we had one row in the data set was one autonomy experience, not a person. And because of that, we sort of had to control for repeat observations. And that's because even if people have 2 different MADAM scores, that still tends to be a pattern to people's responses. So it has to be controlled for. So we did that. We did not include pregnancy losses in this particular analysis, but we have a lovely paper that focuses on that. And then when it comes to coding the MADAM scale, I opted to go with two groups for ease of interpretation, where everybody above the 80th percentile was defined as having high autonomy, and everyone below was defined as average or low autonomy. Now, if we do it that way, then the cutoff score would be 39. That's the 80th percentile. If we combine all the providers together, including also nurses and nurse practitioners and other. But if we do it that way, if you look to the table to the right here, we find that 10% of physician patients are in the high autonomy group, but 50% of midwife clients. So, I mean, that is very disparate. And seeing that made me want to, yes, provide results for all the providers combined, but it also made me really want to create provider-specific cutoff scores and then see within the physician experiences and within the midwifery experiences to see if there is differences in autonomy for minoritized participants. because we hypothesized that if we keep on seeing these differences, regardless of the model of care, that is another piece of evidence that points to structural inequities, because it's not just one model of care, it's across models of care. So in summary, 3 types of analyses, one for all providers combined, and then 2 more, one for physicians, one for midwives. And the only thing I will say here is that in addition to pregnancy year and repeat observations, we also controlled for the pregnancy that was reported on. Was it the first, second, third, fourth, or higher? Because we know that people's experiences and expectations can be different depending on the pregnancy order. And what I'll be reporting here mostly is odds ratios and confidence intervals, but I'll do that in lay language. So we're almost getting to the results, but there is just one last method slide, and that is another validated scale called the Day-to-Day Discrimination Index. It was developed in Canada. It measures not discrimination specific to pregnancy, but across the board in everyday life. Could be healthcare, could be discrimination walking on the street or when looking for housing. And one of the sample items here would be, because of who you are, have you been called names or had your identity used as an insult? And then people have 4 response options, and all of those items get summed up with the highest score of 18 and the lowest score of 0. So then I kind of created 3 categories again for those discrimination scores. And I looked at the correlations between belonging to the high discrimination group and different characteristics and circumstances. And I found that there is substantial overlap between those groups here. Apologies, in the dark orange box, and experiencing high discrimination, which is to be expected. But it's good to check that, because this signals to me that rather than always, look at differences in autonomy or other experiences by individual circumstances or identities, sometimes we can use a discrimination index to serve as kind of a summary for being minoritized, and then also do an analysis with that. And the other reason why we like to do it is because there's now increased focus on moving away from using things like ethno-racial identity alone as a way to infer racism or as a proxy for discrimination, and measure both identity variables plus measures of discrimination and racism. So that's why we included this here. Now, I'm going to go fairly quickly through the all provider results. So this is when all the providers are together. We didn't pay attention to whether it's they're rating midwives or physicians or nurses. And here I'm showing you the groups that experience lower odds of high autonomy. And I've only listed here the ones that had significantly lower odds. And I'm telling you how much lower it was. So we see here the odds of high autonomy were 27% lower for Indigenous participants and 43% lower for Middle Eastern participants, quite low for childbearing people less than 25 years of age, and also really low for people with high school education or less. And the reference group is in the brackets here. I'm not going to say the reference group, but you can see it here. We also found significantly lower odds of autonomy among people with disabilities during pregnancy, newcomers to Canada, people who use substances. And then another important one here was folks who didn't have enough income to meet their monthly financial obligations had 53% lower odds. And then this was like a 3-level variable. Like basically we had, could you meet your financial obligations? Was your income not enough, and more than enough? So even the people who had just about enough income to meet monthly financial obligations, they still reported a loss of autonomy here. Now, this is the last slide about all providers. So we also asked in the survey whether people needed social services during pregnancy. And there were 13 options there, plus 3 more options to write in, just in case we had forgotten about certain social services. And examples there included food banks, resettlement assistance, disability resources, income assistance, so a number of different social services. And especially people who needed 2 or more social services really experienced loss of autonomy compared to those who didn't need any. And also people who were told by their provider that their pregnancy is high risk had quite a bit lower scores. And those with a pre-pregnancy BMI of over 30. And now moving on to the day-to-day discrimination index, we also saw significant results here. So when you compare people who reported a high level of day-to-day discrimination versus none, their odds of high autonomy were 28% lower. And we see a bit of a more muted effect for those with moderate levels of discrimination. Now, I think in conjunction with those findings, it's now important to look at access or interest in prenatal midwifery care, because we know that midwifery care is a big factor that impacts on autonomy experiences. So what you're looking at here is the proportion who had a midwife as their primary prenatal provider. And you can see that Indigenous women and Middle Eastern women had way lower proportions of midwifery access. And they also happen to be the people who had low autonomy in the model when all care providers are combined. And you see the same here for younger age and for less education, for disability, for income, financial struggles. And it's the same for all of the variables that I showed you. I just didn't want to put them all on the slide. So there's the same people who had loss of autonomy, also had less access to midwifery care. And I think that's the reason why it's really important to also look at the results separate for those rating physicians and those rating midwives. And that is what I'm going to show you now. Now, I am trying something out here where I'm going to show you how to interpret these slides, and I hope that the transitions work. So in the title, you basically see what association is described here. In this case, it's the association between gender identity and high autonomy. And then I want you to make sure that you only compare within the blue bars, because this is separated. I'm showing you things on the same slide here because I don't want to have 100 slides, but I would like you to not compare blue to orange, but blue to blue and orange to orange, because these are completely separated analyses. Then the bar graphs, they refer to the proportion who reported high autonomy. So for people rating midwives, 30% of those who identified as cisgender reported high autonomy versus 28.9% of those who identified as a gender minority. So very similar in this case. Then at the bottom here, it will be either a box with a blue outline if it refers to physician findings, or a box with an orange outline if it refers to midwife findings. And this shows you the results from the multivariable models. And those are considered more robust models because they enable you to control for some confounding factors, like year of pregnancy and repeat observations. So I hope that this helps with the interpretation. And the R is the reference group. So when you do a logistic regression model, you have to choose a reference group. And in this case, I mostly chose the majoritized group as the reference group, but that doesn't have to be that way. It could have been done differently too. But as long as you see the white R, you know that we're comparing to this group. This is what we're comparing to in the multivariable model. Okay, so we see here for the association between gender identity and high autonomy, we see some differences really, but not many. And in the multivariable models, the two groups, gender minority and cisgender, had similar odds of high autonomy, no matter if it's rating physicians or midwives. So this is showing the association between ethno-racial identity and high autonomy. And if we separate by physician and midwives, we see differences here. You can see that some groups have lower autonomy when rating physicians and some when rating midwives. But in the multivariable models, we also did not find significant differences by race. And white is the reference group. I forgot to put the R in here. Now, when we look at childbearing people who were less than 25 years old during pregnancy, we can kind of see quite a difference here for people rating physicians, where it goes up steadily as age goes up. And we found that those who are younger had 42% lower odds of autonomy compared to this group here. I'm missing the R here, but that was the reference group, 35 and older. And then if you look at the midwifery clients, it's very similar. In fact, it's a bit higher for the younger participants. So that there is no differences here across age, whereas for physicians there is. Now, moving on to education, we have 3 educational categories here. And for midwives, we did not see differences where people across the education categories reported similar degrees of high autonomy. But for those rating physicians, we found that people who had some high school or high school completed had 33% lower odds of high autonomy compared to participants with a graduate degree or professional degree. And I've got just a few more slides here. Now we're talking about income sufficiency, and this is where we see more of an effect when we look at the stratified analyses. And here we see, for instance, among people rating physicians, the odds of high autonomy were 51% lower for people who didn't have enough income to meet household obligations. And for people who had just about enough income, it was 27% lower. And that was also significant for midwifery clients, that group compared to people with more than enough income. So income seems to be a factor where there's quite a difference in both the all care provider model and the stratified model. Now, when it comes to immigration status, we see different scores here for different immigration categories, but the only significant findings really was among people rating midwives, where newcomers to Canada had 64% lower odds compared to people who had been in the country a bit longer. And I chose this as the reference category because this group had the highest autonomy scores. If we had chosen people born in Canada, these findings would be slightly different, but you can see the lower proportion of newcomers with high autonomy among midwifery clients. Now, a couple more slides here. I know this is a lot. So people who were told that their pregnancy was high risk, there was really not much of a difference for people rating physicians, but for midwives, the ones who were deemed high risk had 41% lower odds of high autonomy. And I think that's good to know. It's an important finding. And then here, this is the last slide of the bar graphs. And this again is showing kind of the summary measure of day-to-day discrimination. And here we can see that people who reported a high degree of day-to-day discrimination had 36% lower odds of autonomy for physician clients and 27% lower for midwifery clients. So we can see those same patterns here of loss of autonomy. So I have one more slide for this part of the results. And again, this is looking a little bit complicated, but I was trying to fit it all on one slide, and I will tell you what it means. So I mentioned that there's several context of care factors that might be associated with autonomy, and you can see those 3 factors right here. So those who rated physicians, which is represented by the blue line, and answered yes to the question, did you get prenatal care as early as you liked? They were more than twice as likely to report high autonomy. So this is the odds ratio here. So early prenatal care, twice as likely to report high autonomy for physicians. Participants who rated interactions with physicians and were easily able to find their preferred type of provider were nearly 4 times as likely to report high autonomy compared to people who could not find their provider easily. And then those who rated physicians, we're still looking at the blue line here, those who rated physicians and felt that they had enough time during prenatal visits were more than 6 times as likely to report high autonomy compared to people who disagreed with that statement. So, and then here, I basically summed up these three conditions. So you received a score of 1 if you agreed. And for physician clients, if all three conditions were met, as opposed to 1 or none were met, that really increased the likelihood of high autonomy to more than 7 times as likely. And then for the midwifery clients, we see some improvements here in autonomy when it comes to early prenatal care and enough time. But really, I think because midwifery clients had a high baseline of autonomy, these contextual factors don't matter as much, but they do matter a lot for people rating physicians. And I think that also shows that women under the care of physicians who have those optimal access conditions will have different autonomy experiences from those who do not have one or more of those conditions. So what can we say here about those findings? We know that most childbearing people want to lead decisions about their care. We know that many experience restrictions on their autonomy, and especially for minoritized service users. And loss of autonomy was observed across different minoritized groups, but seemed to be especially strong when looking at indicators of low socioeconomic standing and then high levels of discrimination. So we do find, and we did know before, that this is a structural issue because we see some of those inequities across physician and midwifery care. So there is a need to address this issue at the core, at the root of it. So what improves autonomy? Definitely access to midwifery care. We saw that clearly. And also, I should have moved that around. I think adequate appointment length is then a really important one, but also, of course, access to a preferred provider and early prenatal care. And the other key message I want you to remember is that midwifery care was linked to the highest autonomy scores, yet was the least accessible model of care among marginalized groups. Just going to have a little drink. Okay, so now we are going to move on to presenting an example of exercising autonomy, and that is declining care that you don't want. Interestingly, there is not much published about declining care from the perspectives of service users. I was thinking the other day that, many years ago, this article was published called Too Little, Too Late, Too Much, Too Soon. And this was basically all about, high-income countries intervening too fast, providing too much care, and then low-income countries not having the resources to provide enough care. And it occurred to me that we publish so much about, statistics with overuse of interventions or underuse, but we don't really talk much about the perspectives of service users, because service users are reacting to this phenomenon, right? In high-income countries and middle-income countries, we know that there's an overuse of interventions, and we know that some people decline interventions, and there's kind of a pushback against those interventions, but we just don't really look at it very much. So on this slide here, I copied a few papers that are looking at this phenomenon, and many of them have been published by team members and collaborators at the lab, including Dr. Mimi Niles and Dr. Rachel Logan. They analyzed data from the US, and then Dr. Mimi Niles and I also analyzed declining care based on a survey of people in British Columbia. And then we have a lovely colleague as well, Marit van der Peel, who studies this issue in the Netherlands. Okay, so the aim of the declining care analysis was to describe experiences of perinatal service users who declined recommended care. We wanted to know how common it is that people decline a test or procedure, what type of care they declined, why they decline, and how providers react. And then we also added some questions we have never added before about procedures that people would decline in a future pregnancy, because the act of declining assumes that you have a certain amount of autonomy and comfort to stand up to the healthcare providers. And we hypothesized that there likely is people who would have loved to decline more things but didn't for one reason or another. So that's, I think, an important aspect of of declining care. And then the second objective was, again, to look at differences in declining care by different levels of self-reported discrimination. So rather than sort of show deviations from the experience for different identities and circumstances for different groups, I only show the level of self-reported discrimination. And specifically, we looked at the proportion of people who declined care, but the provider proceeded anyways. So we also call that unconsented care. So that is the outcome in that analysis. So just one method slide here because I want to focus on the results. So how did we ask about declining care? On the left-hand side, you see the exact wording that we used. And then the people who said yes to that question, they were able to see a whole bunch of follow-up questions that the people who said no would just simply skip. So people who said yes, they saw follow-up questions, such as the one on the right here, where we asked them, why did you decline tests or procedures? And then you'll see at the very bottom here, there's an other please specify. We had a lot of text responses in this section. In fact, my co-author, Yigane, analyzed probably close to 5,000 text responses. And it could have been like just a test or procedure that people wrote in, or it could have been like a whole paragraph that detailed how people were treated when they declined care.
Kathrin, just wanted to let you know you had about 5 minutes left.
Okay, thank you. Okay, so let me see. I'll quickly skip through this. So this is what people kind of declined at the bottom here. And at the top, you'll see the overall percent of people who declined care, which was 46% of participants, which is, I think, very high and something we need to pay attention to. During pregnancy, genetic screening was declined most often, but also lab tests, and in particular, gestational diabetes testing. And then medications were quite often declined, such as, and especially pain medications and epidurals. And then during labor and birth, 1 in 5 declined induction, and cesarean sections and episiotomies were declined by 1 in 10. By far, the most common reason why people declined care was because they thought the procedure was unnecessary, or they had done research and their research did not support use of the intervention. When we asked them how their care provider reacted, 80.4% said their provider respected their decision. 12.1% said that the provider kept asking until they agreed, and 7.2% said the procedure was done against their will. I am going to skip over this and leave you with this quote here. So in this section about how did the doctor, midwife, or nurse react, this is the response of one participant. While discussing my birth plan with my OB, I said I wanted to have a physiological third stage of birthing of the placenta. He compared the decision to not vaccinating new kids. He implied wherever I got my information from was questionable. He tried to scare me into just doing what he said. When I asked for the evidence on something he was trying to scare me about, he said, well, you wouldn't have heard about it before. You're not an OB or even a family doctor. You're a pregnant woman. He made me cry. He asked me why I was there at all if I didn't value his expertise. So this is one of the experiences. And I think I will quickly skip to this one. So I mentioned before, we looked at the proportion of people who declined care and then had the procedure done against their will. So that's the 7.2% of people I showed you on the previous slide. And here we see that participants who experience a high degree of day-to-day discrimination were 3 times as likely to report that they declined care and that their wishes were not honored. And this is very similar to what Dr. Logan found in the US, and kind of adds to the evidence that there really is a difference between being able to exercise autonomy and having your wishes and desires valued and honored. I will quickly just show you this briefly. So this is what people would decline in the future. That's the blue bar graph and what they declined in the previous pregnancy. And maybe I'll just point out here that It sounds like a lot more people would want to decline a cesarean and especially forceps than in reality decline that test or procedure, and also episiotomies, you know. And one of my co-authors pointed out, why wouldn't they decline episiotomies? They're not really evidence-based. So I think a lot of these responses are especially high for procedures that are not really evidence-based. Now I'm going to take, I probably need 5 more minutes to finish up. I'm sorry, Tamar, because I want to go over the recommendations, but I will be fast. So in summary, declining recommended care. I think for childbearing people, that is an expression of autonomy, and it might signal the need for more information that is needed from the healthcare provider, or a need for more compassion and empathy, or a need for more time to discuss options, or a lack of trust or safety, or all of the above, right? There's definitely something going on there when people decline care. And for healthcare providers, it's an opportunity to provide person-centered care and an opportunity to establish or re-establish trust. So I want to quickly point out that the Birthplace Lab has put together a lovely course on person-centered decision-making that requires about 30 hours of time and involves interprofessional trainees. And we need more of those kinds of education courses. We need to, in general, enhance curricula to support the development of person-centered decision-making competencies across the health professions. And we should mandate regular interprofessional in-service training on this topic as well. And of course, we also need to offer professional development and training on topics of diversity, disparities, disability, trauma-informed care, indigenous cultural safety, and respectful care. This should be a universal standard. Now, I will skip over that. I have a few recommendations that you can read about in the paper. But I think I will finish off with something that Saraswati sent me from the maternity care discussion group. This was a discussion about free birth, and there is an obstetrician in Yellowknife who publishes on informed consent and refusal and had some good comments regarding free birth. And it kind of overlaps quite a bit with autonomy. So what he said in this discussion was that we really need to embrace three principles. And one of them is that respect for women's autonomy is fundamental, even if the results will lead to an adverse outcome. And it's also important that we really remember that women are the abiders of the acceptable level of risk worth taking. And occasionally, women choose to accept a high level of risk. And staying with a woman as she negotiates her own risk-benefit choice is the best way to minimize risk and optimize birth outcomes and experiences. And then finally, this is the last slide. As much as possible, be rigorously objective about risk. When you exaggerate risk, it sort of erodes your credibility. And be respectful and meticulous and very non-judgmental. And make sure you accept women's choices, even if they entail a high level of risk. And then down here, I'll skip to this one. When a woman who has previously declined care or recommended treatment decides to accept care or intervention, roll out the red carpet. And I think that's a lovely recommendation because it's kind of that readiness to meet the woman where they're at and roll out the red carpet when there's been a change. So I think I've skipped over a few recommendations, and I'm sorry about that, but I definitely want to leave some time for questions. So I think that's where I'll leave it. Thank you.